Okay, so this lecture series today is going to look at the treatment options that exist for both ADHD and PTSD. Only a few learning objectives. Basically just describe the mechanism of action of these drugs and list the medications that are used to appropriately treat each indication. Let's start with looking at the recycling of neurotransmitter. And so this is a representative example of the mechanism of action of the next couple of drugs that are loosely termed psychostimulants. And essentially what we're looking at is the ability of these drugs to inhibit the norepinephrine transporter, also known as reuptake. So on a noradrenergic neuron, the reuptake is specific to norepinephrine. The same could be said on a serotonergic neuron, being specific for serotonin, or a dopaminergic neuron, being specific for the dopamine transporter. So it's the same concept across the three different neurons, and it's the same diagram, so I only showed one. So the first drug we're going to talk about is methylphenidate. If any of you have friends or family members who have ADHD, you may have heard the drug Concerta. And so this is a drug that is specific for the dopamine and the norepinephrine reuptake inhibition. And by inhibiting these receptors or these proteins, you essentially get more neurotransmitter postsynaptically. The side effects are pretty varied, pretty general in terms of some pathomimetic signs. And so whenever you have too much neurotransmitter in the synapse, you can see these side effects. They tend to be quick adapting, meaning you can see them happening quite quickly. Some of the patients do get suicidal ideations, and so many of these drugs come with a very stern black box warning. Some patients complain of a loss of appetite, which is really the most common, GI upset and GI problems, as well as cardiovascular problems, and ironically, insomnia. The clinical indications for methylphenidate include ADHD and, ironically, narcolepsy, and the formulations are varied. There's a short-acting formulation, which covers the patient from 3 to 5 hours, and of course there's a much longer kind of sustained release formulation that basically lasts up to 12 hours. And so the only kind of difference here is how much coverage the patient would need, especially if it's a younger patient, and how long of a day they're in school. Typically, preschool and younger school children would be only at school for a short period of time, whereas something like maybe a high schooler student could be gone 12 hours per day, especially if they're on a sport or some kind of extracurricular activity. And of course, we can kind of see the various levels of catecholamine release. And basically, you can kind of see these spikes during the day. And so there is an art to managing patients, especially younger patients with ADHD. And we're not going to get into it. I think we'll reserve that for the clerkships. It's not very heavily tested on step one, but at least you should know how these drugs work. The next drug is dextroamphetamine, and this has a similar mechanism of action, but now we're looking at the blocking of the reuptake of all three neurotransmitters, dopamine, norepinephrine, and serotonin. And there's an increase in the release of these monoamines within the synapse. Indications are the same as before, ADHD and narcolepsy, and some of the side effect profile is pretty much the same. Dextroamphetamine does have a little bit more of an emotional liability, as you can expect from some of the more profound dopamine activity of this drug. The duration of action is similar, and similar formulations exist. Atomoxetine selectively blocks the reuptake of norepinephrine and serotonin, and these within the central compartment are more like clonidine, which we'll talk about in a few slides. But the noradrenergic components potentiate more or less in the periphery. Atomoxetine is indicated for ADHD, and it's metabolized by the CYP3/450 enzyme system. The main side effect of atomoxetine is orthostatic tachycardia, and the main contraindication to this drug are patients on MAY inhibitors. Bupropion selectively blocks the reuptake of norepinephrine, dopamine, and possibly some other mechanisms. We're not exactly sure how this works. Bupropion works really well for depression, bipolar disorder, smoking cessation, and a few other psychiatric and other conditions. Its use for ADHD is currently being evaluated. You can expect changes to the formulary and to treatment options probably within the next year or two as those clinical trial data become more promising. In terms of the pharmacokinetics, this is metabolized by a CYP2B6, which is kind of a CYP that we haven't really talked about, but it's really kind of unique to bupropion. The side effect profile can be anywhere from restlessness and tremor to nausea and insomnia. And so the main indication with bupropion is that the patients, if they have a history of seizures, probably shouldn't take this drug because it does lower the seizure threshold. I think what we'll do is stop here. This is the kind of the summary of all of the what I would call the psychostimulants, and we'll pick up with another group of drugs in the next video.